Assalamu alaikum to all of you. My name is Numan Sheikh, and I welcome to all of you on behalf of Farmivo. Before starting the session, I would request Mr. Bilal Hussain for the recitation of Holy Quran. So please.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر صدق الله العظيم.
Jazakallah. So, as we all know that 1 in 4 people die worldwide of conditions caused by thrombosis, and it's a leading cause of death and disability. And there is second wave of COVID-19. And if we talk about the first wave, so we have seen very good and remarkable results of Rivaroxaban in patients with COVID-19, with increased D-dimer or COVID-19. So today we are here to discuss about the management of COVID-19 in second wave. For this today, I would like to introduce our panelists. First of all, I would like to introduce Professor Dr. Rauf Niazi, Head of Department General Medicine and Endocrinology, Diabetes Metabolism in PIMS. He's as a panelist with us, and as well we have a speaker, Dr. Muhammad Ali Arif, Assistant Professor of Medicine and Consultant Physician in PIMS. So I would request Dr. Muhammad Ali Arif, sir, please, you should start the presentation.
Thank you so very much indeed, Jazakallah. First of all, Assalamu alaikum to all of our participants. And I'd like to begin with the permission of the chair. So, aapki ijazat hai?
Please go ahead.
Right, so today's session is going to be about a phenomenon that we do tend to see in our patients who've got COVID-19 infection. And that's going to be focusing predominantly on venous thromboembolism. And we're going to talk very briefly about the whole anticoagulation. At the outset, may I request our participants to mute their mics in the meanwhile so that we don't have any interference. We can have them back on at a later point in time. So let's begin. So first and foremost, just an overview and a basic understanding, putting COVID to the side for a minute. Why anticoagulation? Well, we aim to prevent thrombus formation or the extension of an existing thrombus in the slower moving venous side of the circulation. It's the therapy of choice for primary and secondary stroke prevention in patients who have atrial fibrillation and any of the known additional risk factors. And we aim to prevent blood clots from recurring. So a question that does come to mind is, what's the mechanism behind thrombosis in COVID-19? One would assume that a respiratory tract infection, as essentially is COVID-19, shouldn't be leading to clotting of blood in the circulation. However, the lungs of patients with COVID-19 exhibit all components of Virchow's triad. These include a hypercoagulable state, endothelial injury, and stasis. May I request once again, could you put off the microphones in the meanwhile? We don't want any further interference. Thank you. High plasma levels of several pro-inflammatory cytokines, including IL-2, IL-7, granulocyte colony stimulating factors, IP-10, MCP1, MIP1A, and tumor necrosis factor alpha have been observed in COVID-19 patients admitted to the intensive
ये आपके यहाँ ब्रांच चल रहा है जी जी और कौन कौन से आपके
as in other critical illnesses. May I please once again make a request? Please put the microphones off. We've got a lot of background noise. As in other critical illnesses, this systemic cytokine storm triggers the coagulation system and leads to a hypercoagulable state. There's also evidence of significant endothelial injury, as evidenced by reports of significantly elevated 1 Willebrand factor levels and factor 8 levels. So a consensus recommendation from the Mayo Clinic published an article, Anticoagulation in COVID-19, a systemic review, meta-analysis, and rapid guidance. They concluded that SARS-CoV-2 causing COVID-19 has infected a large number of individuals in our country and worldwide. Infection with this virus has a unique laboratory signature, including thrombocytopenia with elevated fibrinogen and fibrin D dimers, all of which are associated with poor outcomes. Thrombotic outcomes add to the morbidity and mortality and require a thoughtful approach to venous thromboembolism prophylaxis, balancing the risk of thrombosis with the risk of major bleeding. And they presented guidance on prevention and management of thrombosis based on low certainty evidence. We are waiting for further studies that can actually formulate finalized guidelines, but what I will be sharing with you right now is what's available currently. So what do the guidelines actually have to say? We have a patient who has COVID-19, and we should obtain baseline prothrombin time, D dimers, fibrinogen, and a platelet count, and we should assess the patient's bleeding risk. If the bleeding risk is low, that's acceptable, we should encourage mobilization and initiate thromboprophylaxis with low molecular weight heparin or unfractionated heparin. We may need to consider higher dosing for patients at a higher risk. These include those who are obese, have an active malignancy, are immobile, or have undergone surgery, and have spontaneous echo contrast on ultrasound. In those who have a high bleeding risk, we need to encourage mobilization, sequential compression devices when they're not ambulatory, and we should hold thromboprophylaxis. Active routine screening should be undertaken in both cases for venous or arterial thrombosis, which includes cutaneous, pulmonary, deep venous, stroke, line thrombosis, and acute coronary syndrome, which we can undertake clinical radiological surveillance, and we should be following D-dimer trends. We should screen positive or very high clinical suspicion of occult microthrombosis as well. We should consider therapeutic anticoagulation with either low molecular weight heparin or unfractionated heparin, titrated either according to APTT levels or anti-factor 10A levels, and reassess bleeding risk routinely. Thereafter, there should be a transition to either vitamin K antagonists, unfractionated heparin, or direct oral anticoagulants on discharge. And we need to keep in mind drug interactions with either antiviral agents or antiplatelet therapy. This is a generalized overview. I found something very interesting published by the Mount Sinai Institute, and they formulated a COVID-19 anticoagulation algorithm. And this focused on severity, ICU admission, creatinine clearance, and renal replacement therapy. So in patients admitted with moderate or severe COVID-19 infection, classify them either into a high risk, yes or no. They're considered high risk if they've got an increased oxygen requirement, the D-dimer levels are very high, the creatinine is raised, and the CRP is raised. If these criteria are not met, you can use either apixaban, 2.5 to 5 milligram orally twice daily, or enoxaparin. In our setup, that comes under the name of Clexane, obviously, once daily. However, if the risk is high and the patient is admitted to an ICU, you can use a heparin infusion as per the pulmonary embolism protocol, aiming for an APTT of 70 to 110, or you can use enoxaparin subcutaneously twice daily. And you may consider a tissue plasminogen activator protocol as well. If, however, they are not admitted to the ICU, please check their creatinine clearance. If the creatinine clearance is more than 50, please use enoxaparin twice daily, subcutaneously 1 milligram per kg. If, however, the creatinine clearance is not more than 50 and the patient is either on renal replacement therapy, then use apixaban 5 milligram twice daily or a heparin drip protocol. If the patient is not on renal replacement therapy, and there's something I've highlighted for you, which is of strong relevance here, that Rivaroxaban may be used in place of apixaban at any indication. The inclusion criteria in all of this were all admitted patients with moderate or severe COVID-19, and those who were excluded were those with a high risk of bleeding as judged by the treating physician. Once again, just to remind you, we are advised to obtain at onset, that's baseline, and thereafter daily, a complete blood count, PT, and D-dimers. We should hold anticoagulation if the platelet count falls 50,000, or the INR crosses 1.5, or there's evidence of current or recurrent bleeding. If patients take anticoagulation at home, they may be switched to therapeutic enoxaparin or heparin for the duration of hospitalization unless there's an obvious contraindication. Thereafter, when a patient is discharged, consider prophylactic anticoagulation for 2 weeks after discharge. Once again, apixaban or rivaroxaban can be used in an exchangeable format post-discharge. Before proceeding to something else that I'll be showing you, another algorithm of interest, I'd like to focus on quantifying the risk of venous thromboembolism. Every individual who has COVID-19 isn't necessarily going to have a high risk of VTE. We do need to calculate something which is called the improve risk score. This is calculated by assigning the score to each of the items you can see on the screen in front of you. If a patient has had a prior episode of venous thromboembolism, the score is 3. If a patient has diagnosed thrombophilia, a score is 2. If there's lower limb paralysis during hospitalization, the score is 2. If a patient has malignancy actively, the score is 2. If the individual has been immobilized for at least a week, the score is 1. If the patient is admitted either in the CCU or ICU, the score is once again 1. And if the age is more than 60, the score is 1. Now, these scores are added together. And if the score is 0, the risk to 3 months is around about 0.4%. And if the score is more than 5, the predicted venous thromboembolism risk is about 7.2%. Now, just keep this in mind when we discuss the next algorithm. This is something, although which might feel a little bit busy, but I'll take you through it one by one once again. All patients who were admitted with moderate to severe COVID-19, are there any contraindications to anticoagulants, or are there any clinically significant bleeding or platelet count less than 25,000? If that's true, just use pneumatic compression stockings. If these are not true, if there's no contraindication to anticoagulation and there's no significant bleeding and the platelet count is not less than 25,000, then you can go in for prophylactic anticoagulation if there's no high suspicion of VTE. This is recommended for all patients, critical and non-critical, who were admitted with moderate to severe COVID-19. Low molecular weight heparin is preferred to unfractionated heparin. The creatinine clearance is measured. If it's more than 30, then you can use enoxaparin once daily. If it's less than 30, or if there's renal replacement therapy, use unfractionated heparin or apixaban. And as we mentioned previously, rivaroxaban can be substituted. If there's heparin-induced thrombocytopenia, you can use fondaparinux. Now, if there's a high clinical suspicion of venous thromboembolism, we need to look for worsening tachypnea, decreased oxygen saturation when it falls below 90, or you've seen that there's an increased supplemental oxygen requirement in the settings of imaging findings inconsistent with worsening COVID-19, pneumonia, or unilateral worsening limb pain or edema. Do we have time for further tests? That's your clinical judgment depending upon the patient's condition. If the answer is yes, then you can try to use a diagnostic evaluation and stratify a patient's risk. You will do baseline lab parameters, including a complete blood count with the differentials, D-dimers, PTA, PTT, fibrinogen, ferritin, LDH, cardiac troponin, CPK, and CK. In the ICU, you have the facility, you can see the trend of the D-dimers, fibrinogen, FDPs, PT and APTT daily, and you can do imaging in the form for a Doppler ultrasound for DVT, and if you're suspecting a pulmonary embolism, then you can do a CTPA. If you diagnose an acute venous thromboembolism, the patient, if is not already on therapeutic anticoagulation, please shift the patient to therapeutic anticoagulation. If you don't have the time and you need to make a decision quickly, the situation depends upon where the patient is admitted. In the intensive care, you can use unfractionated heparin or enoxaparin in a therapeutic dose, and you could consider TPA. If the patient isn't in an ICU setting, you can use enoxaparin twice daily. If the patient's on oral agents, please shift to low molecular weight heparin because they're less preferred due to an increased bleeding risk in renal impairment. You can think about TPA protocol as well. If the patient has renal impairment, you can use a lower dose of enoxaparin, or you won't need to adjust with unfractionated heparin. If the patient is obese, because obesity is a commonly encountered situation with a BMI of more than 40, you'll need to increase the dose of enoxaparin and decrease it with regards to creatinine clearance. If the patient is pregnant, please use unfractionated heparin. Post-discharge, you've got the opportunity to calculate the improved VTE score, which we discussed just previously. The regimens highlighted a Rivaroxaban 10 milligram daily for roughly 31 to 39 days. Or if you've got other agents available, which currently we don't in Pakistan, that would include Rivaroxaban as well. That can also be considered. So what does the American Society of Hematology have to say? Patients hospitalized for acute medical illnesses are at an increased risk for venous thromboembolism for up to 90 days after discharge. This finding should apply to COVID-19 patients, and it's reasonable to consider extended thromboprophylaxis after discharge using a regulatory approved regimen Rivaroxaban. For us, that would be accept 10 milligrams daily for 31 to 39 days. So why Rivaroxaban? I mean, the thought process could come to your mind, well, why not use good old warfarin? With Rivaroxaban, there's no need for coagulation monitoring. There's a low risk of drug-to-drug interactions. The simple dose fixation makes it very convenient rather than needing to monitor a tedious INR. There won't be any dietary restrictions as you would need with using vitamin K related regimens. The onset of action is fast. Within 4 hours, you start getting results, and you have a convenient once daily dose administration. With regards to safety, the American College of Cardiology has given a global prospective safety analysis of Rivaroxaban, and it shows a favorable safety profile with 96% of the pooled Rivaroxaban population not experiencing any of the events of treatment emergent major bleeding, stroke, or non-CNS side effects, or all-cause death over a follow-up period of approximately 1 year. There are low rates of major bleeding, including major GI bleeding and stroke or non-CNS side effects in these individuals treated with Rivaroxaban. So keeping it short and sweet, Thank you for your time and for your patience. People with COVID-19 are more likely to develop blood clots during and for 90 days after a hospital stay. We need to be aware about this as treating physicians. We need to know about the risk. We need to know the signs we need to watch for. And we need to tell our patients as well that long periods of immobility can lead to venous thromboembolism. From a total layman standpoint, what we can tell them is keep moving after every 90 minutes. They should be aware of warning signs like cramping pain, limb edema, redness and warmth in the leg or arms. They should stay well hydrated, and they should seek medical help if they suspect a blood clot as well. So thank you for your time, and now we'll shift back to our discussion phase. I'd like to ask Professor Rauf Niazi for his comments in the meanwhile, so that we can take things further from there.
Are you able to hear me?
I believe we are.
Right. So once again, I'll repeat, thank you very much, Dr. Ali, for a very comprehensive and neat presentation concerning anticoagulation in obviously the second wave of COVID-19. Before I say something about Rivaroxaban and its use in COVID-19 and anticoagulation, I believe it would be pertinent and very wise to ask the audience if there are any questions. They can put up those questions first. Then I will give you some comments concerning the presentation and my views about Rivaroxaban. So are there questions? Please.
Right, I've got the chat box open in front of me, sir. So with your prior permission, I'm going to see what the questions asked are. There's a question from Muhammad Kalimullah, who's asked, can we add aspirin 75 with it? Now, once again, thank you. It's a very pertinent question here. I'd like to start with saying, has the patient already been taking low-dose aspirin in this time frame? For example, from a cardioprotective standpoint, post-MI, or after a CVA. In that situation, yes, the guideline so far recommends continuing the use of aspirin. However, if a patient doesn't have any previous history and has not been on aspirin prior, there's no add-on benefit of using low-dose aspirin for the prevention of venous thromboembolism in the COVID-19 setting.
Very wisely answered, Dr. Ali. Thank you. Are there any other questions?
Been asked to repeat the mechanism of thrombosis in COVID-19. Thank you so very much for that question once again. As we mentioned earlier, in COVID-19, if I can just pop back the slides for you, if you'd like to take a look, just give me a second there. So the actual thing is, in COVID-19, there is a hypercoagulable state that exists. There's endothelial injury and there's stasis of blood flow. At the same time, we've got lots of pro-inflammatory cytokines that are being released into the circulation. I repeat, that includes IL-2, IL-7, granulocyte colony stimulating factor, IP-10, MCP-1, MIP-1A, and TNF-alpha. These have all been observed in the circulation of those individuals with COVID-19. At the same time, there's also significant evidence of endothelial injury, and patients who had their own Willebrand factor levels and factor 8 levels measured show an increased level of that as well. So you add all of these things together, that leads to an increased chance of thromboembolism in individuals with COVID-19. So let's move to, okay, we've got another question here. which regime is currently recommended for COVID of patients who have normal symptoms? I'd like a little clarity in this question, if I may. If you're talking about individuals who don't have any risk of venous thromboembolism, and especially those with mild disease, those who are being managed outside the hospital, then there are no recommendations for anticoagulation in these individuals. For example, when I came down with COVID in July, the only thing I had was a loss of sense of smell. So knocking myself up with either enoxaparin or any other agent wouldn't be a very logical stance, since I'm a young adult with no add-on risk factors. However, once again, you have to individualize if a patient has decreased mobility, if a patient has previous history of venous thromboembolism, if an individual has an existing cancer, if they've got an old cardiac event, if you've got factors that could add up to an increased risk of VTE, use the improved score, and then you can decide about the use of anticoagulation in a hospital, in a ambulatory setting. However, for patients who were admitted, that would ideally be highlighting either moderate or severe disease, the first line agent in our setup would be enoxaparin. Monitor for creatinine clearance. Keep in mind that there are relative contraindications where you could use other agents as well. You may want to use unfractionated heparin if there's a creatinine related issue, a creatinine cutoff of less than 13. The regimen does allow for apixaban or rivaroxaban, but once again, you have to individualize according to your patient. You have to weigh out a risk of bleeding versus the possible risk caused by the venous thromboembolism. Another question which we have down the line, can we increase the dose of oral anticoagulation drug to 2-hourly dosage in severe disease on discharge? It's a very nice question. The guidelines, to be very honest with you, are slightly silent on that aspect. They haven't mentioned increasing oral drugs on discharge. If a patient needs therapeutic anticoagulation, then you can continue with using enoxaparin twice daily. Or if you've started using rivaroxaban for a DVT, that's 15 milligram twice daily for 3 weeks, and thereafter 20 milligram once daily for another 3 months or so, you could continue with that regimen. The guidelines have so far highlighted prophylaxis thereafter. These are conditions in which an individual may not have developed an acute thrombosis, which has been clinically documented in the hospital setting. So if an individual has already developed venous thromboembolism, then by all means use a therapeutic dose. However, if you're going for prophylaxis, then a very convenient once daily dose is something that you can use. A question which has been dropped further, is COVID-19 associated with an increased risk for venous thromboembolism? Yes, it is. That's why we've highlighted that it in itself leads to a hypercoagulable state, and you need to monitor closely for the development of VTE. Another question which states, is this bioequivalent drug? Can we use it instead of brand safely? That's something I believe you're going to have to ask the manufacturers, although I do believe they've conducted bioequivalent studies as well, and I'm sure they can share those studies with you, which have shown equivalent bioequivalence to the original brand. So have some faith in our local manufacturers as well. We need to get out of this complex of depending upon the West for everything. You have a good line of local manufacturers which are doing really good jobs, but rather than endorsing anything further, I'll leave them to talk about bioequivalence at a later point in time. We have another question. A 61-year-old male patient, known hypertensive with a history of angioplasty 8 months back, now taking Loprin 150 and Plavix, that's clopidogrel OD. In this scenario, if the patient gets mild COVID, will he be needing other anticoagulants apart from aspirin and clopidogrel? Once again, we'd go back to the improved VTE risk stratification. The individual is 61 years of age. That means I'll give him 1 point there. The individual has a history of cardiac disease. I'll give them 1 more point over there. But other than that, you haven't mentioned any existing VTE in this individual. They don't seem to have any underlying malignancy, or maybe we haven't diagnosed that as yet. They're not admitted in either the CCU or the ICU. They don't have any sort of immobilization, so the score is still 2. That would give a VTE risk of roughly 0.8%. Which is not very severe, mind you, and the individual is already on dual antiplatelet therapy. In this situation, considering that the diagnosis of COVID is still mild, I would recommend, and Professor Niazi will comment further thereafter, but to err on the side of caution. You have to make sure you're balancing a bleeding risk with the risk of venous thromboembolism. So since this individual is already on aspirin and clopidogrel, please do monitor. You may wish to use compression stockings. Keep in mind that mild COVID can turn to moderate or severe COVID in a matter of days. So keep an eye on the individual. The situation will change if the individual develops moderate disease. Thereafter, you may require a shift to prophylactic anticoagulation, but in this scenario, I think watchful waiting would be more advisable.
Very wisely put, Dr. Ali. I think the scenario shows that this patient doesn't require any anticoagulation, neither with enoxaparin nor with Rivaroxaban. But yes, things change and the patients change. So one has to monitor, do their markers, and obviously if the D dimers are rising or the CRP is rising or there are other risk factors which develop, then the patient might require further anticoagulation. But the scenario which has been put up, it does suggest that this patient doesn't require any anticoagulation. I'm talking about the 61 years old male who's on dual antiplatelet drugs.
Thank you, sir. Another question highlights COVID-19 anticoagulation recommendations in children. So very interesting question there, but as you know, thus far, by the grace of God, children haven't really been affected with that degree of severity as adults have with COVID-19. The guidelines are still quite silent as far as children are concerned. And quite frankly, I'm going to have to ask Professor Saab if he's got any further understanding with regards to management of COVID in children, because predominantly in the last 2 waves, our focus, or rather our experience, has been predominantly in the adult population. So if you've got anything to add on that, frankly, I don't have anything to put forward right now. The guidelines, in my opinion, are still quiet. I think Niazi Saab's connectivity might have dropped for a second. No issues, we'll get him back and then repeat the question thereafter. This is an interesting question. Which of Apixaban and Rivaroxaban should be the preferred choice, as both are currently available in Pakistan? That, I believe Dr. Vaji Sahab has asked this question. Once again, I believe that's going to be personal preference more than anything else. Both drugs have a different pharmacokinetic profile. With Apixaban, generally you need twice daily dosing. With Rivaroxaban, you do have the advantage of a once daily dosing. The creatinine cutoffs differ between both drugs. So you'll have to individualize, taking in mind your patient and overall your own patient preferences at the same time. So what level of D dimers justify starting anticoagulation therapy, and how often to monitor D dimers? Well, in the guidelines that I've taken a look at, a cutoff of 1,000 is significant. If it's 700 and rising, that's also significant. How often to monitor D-dimers, that depends upon the setting in which the patient is. I mean, in an intensive care setting, please do it daily. In an individual who's on the floor with moderate disease, you can do it every 48 to 72 hours. So a cutoff of more than 1,000, definitely. 700 and rising, another cause of concern. And how often to monitor in the intensive care, daily, and thereafter in individuals on the floor, you can go in for either 48 to 72 hours. Professor Niazi, I think you've rejoined us as well. There was a question which was regards to COVID-19 anticoagulation recommendations in children. My stance was that the guidelines are still relatively quiet because COVID-19, thank the Lord, hasn't been encountered to that degree in the pediatric population. But if you've got any further insight, we'd welcome that as well right now. Can you hear us, sir? No, sir. Right, I think we'll give sir a little moment to get the mic reset, and I'll move on with the next question. Any roles of statins because of endothelial injury? Theoretically, for the purpose of a discussion, yes, that could be a possibility. However, the guidelines right now don't recommend any add-on of statin therapy. So for a theoretical standpoint, for our conversation and discussion, perhaps, but the guidelines still haven't recommended statin therapy in COVID-19, especially with regards to venous thromboembolism. So a 38-year-old male with repeated chest infections for the last 3 months. What's our recommendation about it? Kindly guide. So we have a young male with repeated chest infections. I'd like to focus on why this young man's having chest infections. I don't believe that venous thromboembolism would have a role to play in an infective etiology of the chest. And I don't believe that with this limited data, actually recommend using any sort of anticoagulation therapy in this individual. I would like to figure out why he's having repeated chest infections, however. And for that purpose, I think we can have a discussion at another forum. Right now, we're going to be focusing predominantly on venous thromboembolism in the setting of COVID-19. So this is repeated. Can we add a statin? Well, just from a COVID-19 standpoint, as I said, the guidelines are silent. However, if you feel that your individual has a cardiovascular risk or has atherosclerotic coronary vascular disease and isn't receiving a statin, feel free to add on. So another question here is, what is the recommended venous thromboembolism prophylaxis in patients with COVID-19? I believe in the 3 algorithms that I shared with you, we went over that in detail. Stratify your patient according to mild, moderate, or severe. Calculate the risk of venous thromboembolism. If moderate to severe, ideally use low molecular weight heparin in an OD dosage. You can consider using either Rivaroxaban or Apixaban, but ideally in a hospital setting, please stick to an injectable mode of therapy. If the case is mild, think about the venous thromboembolism risk on the side, and you can use oral drugs if indicated. If severe, go in for for like twice daily therapy. That's what the guidelines have to say. How long should the anticoagulant therapy be given? Post-discharge, ideally 31 to 39 days is what the guidelines recommend right now. So what's the duration of anticoagulants if someone develops VTE during or immediately after COVID, despite of being on anticoagulants? It's a very valid question. Then we'll be shifting from thromboprophylaxis to actual anticoagulation. If you have, once again, then you'll be picking up guidelines guiding you further to the management of venous thromboembolism. We're moving now to management rather than prophylaxis. So if you've got an identifiable cause, 3 months. If you couldn't pick up an identifiable cause, please continue for 6 months worth of therapy. In which values of these labs we said or suspect patient towards COVID-19? And the question further says D dimers. I'm afraid I don't really grasp the question in its entirety, but from my understanding, I think what you're saying is what cutoff of D dimers would you think that a patient has an increased risk of thrombosis with COVID-19? Once again, a D dimer of 700 and rising, or a D dimer of more than 1000. I agree, different laboratories do use different measurements. Some labs have given a cutoff of 0.5. In that case, anything more than 1 becomes very significant. Between 0.5 and 1 would border on our usual cutoff of 700. We've had, okay, LDH, serum ferritin, CRP, and D dimers. Okay, when we talk about all of these markers, we need to consider that on one side, you've got venous thromboembolism, and at the same time, you've got something that we call cytokine release syndrome. Focusing predominantly on venous thromboembolism, think about your D dimers, your FDPs, and to a certain degree, your CRP. When we're thinking about cytokine release syndrome, you can add on LDH ferritin along with CRP and the D dimers. So if you want to keep it simple using one marker, then D dimers should be something that can guide you with regards to the need of thromboprophylaxis. So another question, if a patient on anticoagulation on novel oral anticoagulants for any other reasons develops COVID-related venous thromboembolism, what should be the approach? Shall we continue with the NOAC, or warfarin could be an option? Now, if a patient is already on anticoagulation and develops thromboembolism, then you need to move to rather than prophylaxis to therapeutic anticoagulation. If you want to step up and the patient's in a hospital, then you can, and guidelines do recommend shifting to injectable therapy, either with low molecular weight heparin, like for example enoxaparin, or with unfractionated heparin. Warfarin is something I wouldn't even want to consider, because once again, in a hospital setting, you're using polypharmacy, you're using a lot of other drugs at the same time, which are liable to interact with warfarin, and achieving a target INR is going to be another burden, both for you and for a patient. Please remember, we are walking a tightrope. At the same time, we want to prevent bleeding. At the same time, we want to dissolve a clot. So if a patient who's already on NOACs for any other reason develops COVID-related venous thromboembolism in a hospital setting, ideally shift to low molecular weight heparin. Or if you want to continue with NOACs, move to a therapeutic dose. Either options can be considered, keeping in mind the patient's overall needs and requirement, the age group, the creatinine clearance, the calculated risk for bleeding as well, and then you can individualize. In my humble opinion, and we'll take Nyazi Saab's opinion as well, I don't believe warfarin should be an option in this situation.
Totally agree, Dr. Ali, with your comments. I think you wisely put it there. Nobody would be wanting to use warfarin. And you rightly pointed out, if for some reason you are not able to use NOACs, then enoxaparin or unfractionated heparin is the choice.
Thank you for joining us again,
You-
sir. There was a question that I wanted to deflect in your domain, which was regards to venous thromboembolism prophylaxis in children with COVID-19. So
Yes.
once again, the guidelines were a little silent, and I thought maybe we could have your expert opinion on this as well.
I think the same thing has been applied to the children as well, since new recommendations for children haven't really come up, but the same applies for the children as well, because COVID-19 infection is a unique infection. And as you pointed out in your second or third slide, it leads to a cascade of mechanisms which leads to coagulation. That's not only unique to elderly, but happens in young people as well as children. So they would require the same protocol, and we know the doses have to be adjusted according to the body weight. Age doesn't make much difference, both in Rivaroxaban or body weight doesn't make a huge difference if you're using NOACs. But obviously, a dose of enoxaparin or unfractionated heparin that needs to be adjusted according to the body weight. So only thing you need to do is adjust the dose according to the body weight. In case you're using, hello, somebody seems to be interrupting. Right. So I believe when somebody's speaking, it's wiser that you keep your mics off, and you have a question, then you can raise your hand. There is an option here where you can raise your hand and then you can speak. In case of children, I believe when you're using Rivaroxaban or Apixaban, they are safe to use, and the same protocol as for the adults should be applied for children.
So there was another question with regards to statin therapy in venous thromboembolism is in the context of COVID-19.
No, there is no role at all.
Well, there's no
No role
document.
at all.
However, if an individual has a high risk of atherosclerotic coronary vascular disease and for some reason isn't on statin therapy, then I believe you could offer him that therapy, but it wouldn't have any impact on VTE in this scenario.
Remember, one thing I would like to point out is when we're using, you remember when we're using Claricid or when we're using macrolides in treatment, combining it with HMG co-reductase inhibitors would increase the chances of rhabdomyolysis. So I would be very wary of using statins in these situations and rather withhold statins till the patient has recovered. It's not an emergency. It's not going to save a life. Obviously, statins can be added on later when the patient has totally recovered. So my take on that would be a big no to statins during treatment when you're treating acute COVID infection.
For the purpose of the audience, if I may just take what Niazi Saab said and add a rider to that as well, the predominant reasoning is that in a vast majority of COVID-related patients, you are using either azithromycin or clarithromycin. Commonly used in COVID-19 patients, whether advised or not is a different debate altogether, but most prescriptions that you will see, even if you're dealing with COVID in the outpatient or with patients who are being admitted, they're either receiving injectable or oral macrolides. And as Niazi Saab's very rightly pointed out, adding on a statin to that already existing prescription would be a recipe for disaster because of the risk of an add-on case of rhabdomyolysis, in which rather than doing the patient any benefit, you'd actually be doing harm. So although statins may have theoretical benefits, but if you are considering using macrolide therapy or you're already using existing macrolide therapy, let's try to minimize the add-on further and stick to those things which do have a proven clinical benefit.
Thank you for Dr. Ali for elaborating it.
I believe we've come to the conclusion of the Q&A. Okay, there are a few more. Hold on one second. More here. Right. So should seriously ill COVID-19 patients receive therapeutic intensity anticoagulation empirically, for example, in the absence of confirmed or suspected venous thromboembolism? That's a very, very nice question that you've put up there. And in the algorithms that I shared previously, this was already highlighted. If you have, for example, D-dimers that are 700 plus or rising, or 1000 and going up, and you believe that your patient has a high risk of venous thromboembolism, you can shift low molecular weight heparin from a prophylactic dose to a therapeutic dose. If you have the availability or the luxury of getting a Doppler ultrasound done, or if you're suspecting, God forbid, a pulmonary embolism and you can get a CTPA done, please do go ahead. But in a lot of situations and circumstances, your patient isn't well enough to go for diagnostic evaluations. They're in isolation, they're being managed separately, and you can't move machines around. So if you do have an index of suspicion and the inflammatory markers that you're using are indicative of underlying venous thromboembolism, at the same time the patient is seriously ill, please do give them the benefit of the doubt. The only thing that you do need to consider is the risk of bleeding, and that's something that you're going to have to assess prior to commencement of therapy.
One thing, Dr. Ali, I wanted to add here is that for the sake of clarity, now, as the American College and other authorities have clearly outlined, that only in case, let me ask the audience, what do you know about Rivaroxaban? How is it metabolized? So you can put on a mic, any one of you can put on a mic and say, speak. Don't hide behind the screens and switch on the mic and say something. I can see a lot of names there, a lot of familiar names there. So don't take it as a threat, but I know all of you almost. Anybody get to tell me how is Rivaroxaban metabolized in the body?
Hello, sir. Assalamu alaikum.
Walaikum salam.
Sir, Dr. Zunaira here.
Zunaira.
Hope you're doing good, sir. So it
Thank
is
you.
metabolized by the, I think, CYP system in the liver.
Yes. So
Oxidative,
two-third of that is metabolized in the liver, and one-third is excreted by the kidney.
In an unchanged form.
Okay, so there are dual excretion routes. So that's why if you have severe renal impairment, then Rivaroxaban is not a good choice. Or you have severe hepatic metabolism problems, that is another no to giving Rivaroxaban. But otherwise, comparing low molecular weight heparin to Rivaroxaban, I think they are both equally efficacious. And now with the new evidence, with the safety of Rivaroxaban, we know that we can use it without monitoring, without fear of drug interactions. And obviously, it has a good safety profile, except for slight increased risk of GI bleeding. It can be used very safely in these patients. And initially, you can use twice daily doses. And when you having the patient to go on a discharge, you can put the patient on once daily dose. So if I had a patient,
thank you, sir.
If I had a patient, I can use either low molecular weight heparin, or I can use Rivaroxaban or Apixaban with the same efficacy and without any fear that I would be compromising in terms of efficacy. So one has to remember that oral NOACs are as effective as unfractionated heparin.
Thank you, sir.
Only scenario, remember, is when there's severe renal failure, or when there's a pregnant female, where you would like to use only unfractionated heparin and not use rivaroxaban or apixaban. So there are two contraindications. Otherwise, they are equally efficacious. And perhaps for me, it's more easy to give oral drug rather than intravenous and get the same results.
Thank you, sir. There's another question, which, although not exactly related to venous thromboembolism, but that's a very nice question. I saw few of our colleagues prescribed moxifloxacin once daily for 10 days. Is it beneficial in COVID? So what's your take?
Oh my, I don't think moxifloxacin at all should be used. And there are several reasons, because it's an enzyme inhibitor. We know all the fluoroquinolones are enzyme inhibitors. And we're talking about metabolism of, for example, rivaroxaban by P450 system. And we are using sometimes macrolides as well. And we're giving vitamin D in most of the patients. So it would lead to a chaotic situation. I don't think quinolones should at all be used in management or treatment of patients who have acute COVID setup or they have acute COVID infection. I would rather go for macrolides, or if there is severe infection and the CRP is high and ESR is rising, TLC is very raised, there is procalcitonin is very raised, which is indicator of infection, I would rather use cephalosporins, third or fourth generation, rather than use fluoroquinolones. So that's my take, and I think that's the answer really for these acute COVID infections.
Thank you, sir. We have, I believe, what seems to be the last question for now. Should COVID-19 patients receive post-discharge thromboprophylaxis? Once again, let me refer you back to the algorithm I presented at the end. Please calculate the improved VTE score. If there's a risk of venous thromboembolism down the line, please use thromboprophylaxis. However, if there's no major risk, the patient's doing all right, then you may decide not to use it. It's going to be varied from patient to patient. But however, if there is an increased risk, please use thromboprophylaxis, and guidelines do recommend using rivaroxaban 10 milligrams once daily. And
there's another question, Dr. Ali.
Yeah, it just popped up in front of me. Is there absolutely chances of thrombocytopenia in COVID patients, which leads to cardiac arrest that was first highlighted by doctors in Italy? Yes, thrombocytopenia has been documented in COVID-19 infection. However, is it part of DIC related to COVID? Is it a consumptive coagulopathy that's going on? I'm really not too sure. But with patients who do have thrombocytopenia, obviously your thought process regarding anticoagulation will change, and you'll be inclined to proceed with further caution. And so if you want to add anything on there, please feel free.
Oh, yes. Again, Dr. Ali, D dimers play a lot of role. If your D dimers are raised along with thrombocytopenia, obviously it's indicating consumption coagulopathy. And that means, again, the role of these anticoagulants, that is rivaroxaban, apixaban, or unfractionated heparins. And that's going to be a lifesaver. And you don't have to worry about thrombocytopenia at that stage, because that's consumption coagulopathy. And if you reverse it by giving these drugs, the platelets, amazingly, they go up, they rise. And you've seen it, you've been managing, and I've been managing, being the chairman of the committee. I've seen patients when they put on, they're with low platelets and the T dimers are raised, when they're put on either NOACs or they're put on enoxaparin, their obviously platelets rise. So that shows it's a consumption coagulopathy. And most of the cases which I've encountered with low platelets, they have been consumption coagulopathies. And treating them with obviously doing the right tests and documenting that it's a consumption coagulopathy would lead you to the right treatment and save a life.
Another very interesting question. Okay, sir, then should it be treated as viral, or there is severe lower respiratory tract bacterial infection as well? By what I'm trying to understand here, I'm just trying to get the question in the meanwhile. COVID itself is a viral infection. There's no doubt about that.
Yes,
That's why it's not a bacterial infection. Therefore, the blind use of antibiotics in every patient with COVID-19, I believe, is something that you shouldn't be doing in the first place. That's why you've got other markers to follow. You've got procalcitonin levels that can guide you further. If you are planning to use an anti-IL-6 agent, for example, tocilizumab, you do already know that you can be causing a superadded bacterial infection by weakening the immune system. Therefore, you would want to use antibiotic cover as well. If the CRP, ESR, the TLC count rises further, the procal rises further, then definitely manage on the lines of a bacteria, or I'd say a co-bacterial infection, because with an underlying viral infection, you can have a superimposed bacterial infection as well. So your take?
I'd like to point out, Dr. Ali, you mentioned procal. Procalcitonin has a very important role. And obviously, you rightly said co-viral infection. I think that's the word to use. So it's a viral infection. If your procalcitonin is rising, then that means there is a secondary bacterial infection. And then you would require antibiotics. And you wisely put it up. No need to give antibiotics. But if your procal goes up, then that means there is a secondary bacterial infection. And that would require either one of the macrolides or cephalosporins or maybe a penem to treat the infection, because you do not want to lose your patient.
Absolutely.
The infection in these viral infections are usually gram-negative organisms, so you want a broader cover. You want both gram-positive and gram-negative totally covered, especially in hospital setting, a pseudomonal cover. So third-generation anti-pseudomonal cephalosporin or a penem, which provides cover for pseudomonas. That would be an ideal drug to use.
Right, sir. Now, this is a very interesting question. How will you differentiate between consumption coagulopathy and heparin-induced thrombocytopenia in this complex scenario? I feel like I'm sitting in a clinical exam.
I think, I'm sorry. This is not COVID cough. Well, we're not using heparin in most of the patients. So we're not talking about heparin-induced thrombocytopenia. With the enoxaparin and the these low molecular weight heparins, we do not get hit. That means we do not get hit, means we do not get heparin-induced thrombocytopenia. So, however, if you're using heparin, that will be a difficult situation. One would be very difficult, it will be very difficult to find out. But luckily, at PIMS, we've not been using heparin. We've either been using low molecular weight heparins, the enoxaparin or other ones, or we've been using these novel NOACs.
Thank you, sir. Another question, which I believe you've already highlighted, is there any recommendation of using IV ceftriaxone in COVID-19 patients with pneumonia or chest infection? Let me just double back here for a second. We mentioned that although COVID-19 is a viral pneumonia, there are chances of a concomitant co-infection with bacteria as well. In those situations in which you're using procalcitonin primarily as your guide, if it's going up, then you're going to need to cover, because in most of these situations, as Sir already pointed out, you're aiming for gram-negative coverage. So ceftriaxone, ceftazidime can be options that you could consider in treating co-bacterial pneumonia in a patient with existing COVID-19 pneumonitis.
One of our colleagues has pointed out that enoxaparin rarely can cause HIT. Well, if you look at the molecular structure of heparin and the low molecular weight heparins, you can find out, and I'm not going to go into detail, I'll let the person look it up herself or himself. Well, that he himself is written down. I don't know who's the person. I'm sorry, the name is not coming up. You've seen that he's written down rarely. Well, rare is rare. When there is something present, when you hear hooves, as the old saying is, think of horses, not zebras. So when I hear hooves in a city, I think of horses. I don't think of zebras. So yes, rarely may occur, but that's a rare phenomena. So one should think about common things first rather than rare things. That's my answer to that question.
Rightly pointed out, sir. And I'm looking back at the chat box, and it seems to be clear from here. Okay, we have another one. I mean, nice to see that people are interested today. Will guidelines for venous thromboembolism prophylaxis in reinfected COVID cases be the same? Although,
oh my, Ali. Look,
sorry, sir?
let me answer.
Please.
This reinfection thing. Oh my God. Well, there have been anecdotal reports that reinfection may have occurred in few patients. I think 10 of the cases were recorded, but there is a lot of doubt whether they were reinfections or not, whether they had COVID infection in the first place and COVID the second time, or it's some other infection. But so far, all the authorities, and there are studies which have documented, once you get COVID-19 infection, you develop immunity. Now it's very clear. You develop immunity, and the immunity, the recent published research, which was a RCT trial, it's been recently published. I think, I don't remember the name of the journal, but it was a peer-reviewed journal, and it clearly showed once you get infection with COVID-19, you develop antibodies. Once you develop antibodies, you cannot be reinfected. So people who had, for example, COVID-19 infection in January in 2020, they are still positive with antibodies. So we now know that the antibodies do last, and they do last, at least now we know, for 12 months, a year or so, and you stay immune to COVID infection, reinfection. So far, authorities do not believe that you can be reinfected with the same virus. But things will become more clear with time. But this question, I think reinfection so far has not been accepted or admitted by authorities who are dealing with COVID-19.
Thank you, sir. It's also 2:10, and I believe that The chat box has been quiet for the last 2 minutes. So Bilal, Numan Saab, I think over to you if you have anything else to add from our colleagues at FarmEvo.
Now, I
So,
would
sir,
like
I
to
think,
make another final comment,
Please, sir.
and that is
sure.
not because we are on this forum. Understand one thing. It's very clear now that unfractionated heparin, low molecular weight heparin, or NOACs, that is Rivaroxaban or Apixaban, they are equal in efficacy. Please look at their renal functions, look at their liver functions. If they're compromised, then go for unfractionated or low molecular weight heparin. Do not give NOACs. If they're not, NOACs are as efficacious as low molecular weight heparin or unfractionated heparin. So, and it's easy to monitor, and the side effect profile is less. There's no drug interaction. And as Dr. Ali, in the beginning of his presentation, said a big no to warfarin. Yes, no warfarin, because I don't want the drug interactions. And I do not want to go on monitoring INR every day. In these cases, we do know NOACs have no their antidote. Unfortunately, that's not available in Pakistan as yet, but they have their antidote as well, and that works. And unfractionated heparins have short half-life, and stopping the drug would reverse if there is any chance of bleeding. So both are as efficacious as possible. So you can use either one of them. But please look at the renal function and the liver functions. And remember, if you're dealing with a pregnant female who's got COVID-19, or you've got somebody with renal impairment or liver impairment, then please use these enoxaparin thing rather than using NOACs. But they're both very efficacious, or almost the same efficacy. And I thank you all the audience for taking part, and Dr. Ali for making a wonderful presentation. And I think it was one of the best presentation on COVID-19 and anticoagulation I heard. Congratulations, Dr. Ali.
Thank you,
And
sir.
you made it very easy. And when you answered the questions, I was really enjoying the way and the authority which you, and the knowledge behind which you were giving all these answers. And
Thank you, sir.
that made it very clear for everybody to understand all these things. And I'd like to thank the platform we are speaking from, that is FarmEvo, for giving us this opportunity to talk to the audience and convey the message and knowledge, a little bit of knowledge we have in managing these patients. So thank you to the audience, thank you to Dr. Ali, and Jazakallah to FarmEvo for having this session.
Exactly, sir. It is the wonderful presentation so far by Dr. Ali on COVID-19. And just in the end, I would say I'm very thankful on behalf of Mivo to Dr. Ali for this wonderful presentation. And definitely, I'm thankful to Professor Dr. Rauf Niazi for today's time and to be a part of this wonderful presentation.